Madam, please start.
Okay. Good evening, everyone. I am Dr. Pranoti Jadhav, and on behalf of MahaIP 2025, I welcome you all to this webinar on pediatric gastrointestinal diseases from diagnosis to practical management. I now welcome and invite our President, Dr. Sanjay Pakmode sir, to kindly address our online delegates.
Namaskar. Good evening all. Thank you, Pranati. I welcome you all this on the platform of the MahaIP digital platform. And every Friday, we are doing some academic activity. And today, we have chosen the topic of gastroenterology. Last month, we have done nephrology. So this particular topic, because in the means our diagnosis is made not by the storytelling by the patient, but by the whatever observed by the parents. So it is most of the time it becomes a difficult challenge for us to functional abdomen distress and other things also to diagnose. We really need a third eye, and for that third eye we need a knowledge. And the way we have addressed our today's meeting, that is, if you ask the right question, you will get the right answer, and you will point to the right diagnosis also, and you will avoid the unnecessary investigations and a lot of confusion and the proper managements. Today's function, Dr. Madhuri Ingre Madam from Chhatrapati and Dr. Bhushan Mir from, and today's presenter, Mr. Dr. Raunak Nair, and all my colleagues of MahaIP, Dr. Sanjay Deshmukh, in the absentia, Dr. Amol Pawar, Dr. Pankaj Agrawal, and Dr. Manish Tiwari, and Dr. Pranut, MahaIP office bearer who have joined today's. So with this short discussion, I welcome you all on this MahaIP platform, and let's hear from our experts reach to the proper, means how to treat the proper patient in GI cases. Thank you. Thank you.
Thank you, Dr. Pakmode sir, for your insights and wisdom you have shared with us today. I now invite MahaIP convener, Dr. Sanjay Deshmukh sir, to kindly speak a few words.
Good evening. On MahaIP academic platform, as a convener, I welcome you all. As rightly said by our president, Dr. Pakmode sir, this is a platform where we want to give a chance to the young students to represent on this platform under the guidance of the experts. And this specialty series, this is the third activity. And today we have the discussion on the gastroenterology specific diseases. I welcome today's presenter, Dr. Raunak Nair. We have the expert, Dr. Vibhor, Dr. Bhushan sir, and Dr. Madhuri ma'am. And I hope this will encourage more and more students to join and to listen, to crack the difficult cases, and that will help them in their academics. I welcome all the MahaIP office bearers, Manish Tiwari sir, the treasurer, Dr. Ravindra Sanone, secretary, Dr. Amol, and all the MahaIP members. So welcome you all, and thank you.
Thank you, sir. Thank you, sir. I now invite Dr. Manish Tiwari sir, HOD Pediatrics GMC Nagpur, to kindly introduce our moderator, speaker, and experts for today's session.
Thank you, Pranati.
May I request all of us please kindly mute themselves? Can I have the slides, please?
Are slides visible, sir?
They are visible, ma'am.
Actually, to introduce a dear friend like Vibhor, I don't need any slides right now. He's cut. So, Dr. Vibhor is a dear friend of mine.
I guess we got disconnected. Yes.
Yeah, sir is not in the participation. Will he be joining us?
He is
Pranoti, you
getting
can take one. I think
reconnected.
there is
Sir
a
is getting
network problem.
reconnected, sir.
Yeah.
Manish, sir.
Pranoti, you can take over if Manish sir has some network issue.
Okay, sir.
You can introduce us.
Okay, sir. Dr. Vibhor Borkar, sir, is Director, Pediatric Gastrohepatology, Gastroenterology and Transplant Medicine at Gleneagles Hospital, Parel, Mumbai. Sir is mostly focused in his work in pediatric IBD, metabolic liver diseases, therapeutic endoscopies in neonates and pediatrics.
Thank you, Pranoti. There was some connection error, I guess.
Sure, sir.
Yeah.
You can take over, sir.
Yeah. Today our presenter is Dr. Raunak. He's currently pursuing his fellowship in pediatric gastroenterology at Sion Hospital, Mumbai. And to the two eminent experts which we have today is Dr. Bandhuri Engade, ma'am. She has received her training from the reputed PGI Chandigarh in pediatric gastroenterology. Currently, she is working as head of department and professor at MG Medical College, Chhatrapati Sambhaji Nagar. Her area of interest are pediatric gastroenterology, hepatology, and nutritional neonatal cholestasis and functional abdominal pain in children. And the next is a colleague of mine, Dr. Bhushan Mirze. He has received his training from Sion Hospital. He has been trained in liver transplant from Chennai. He is currently working as associate professor at GMC Kolhapur, and he has many publications in his name. He has worked for the grid module for IAP this year. He is a guide and a PG examiner as well as a teacher. His areas of interest are pediatric liver disorders and liver transplant. Now, I would request Vibhor to take over.
Hi, good evening. Thank Mahavi to give us opportunity and on this illness. So, in short, today we'll be presenting two important cases. Ronak will be presenting and he is very a bright fellow of ours at Science Hospital, and Dr. Mahavi and Dr. Bhushan are the experts. So with two cases, so both these cases are not diagnostic challenges. These are very common cases seen by everyone of us. What we'll be focusing on how to practically handle these cases in our day. And the first case, a little bit longer, will take 40 minutes, and then whatever slides will cut short, and then we'll summarize and we'll resume to the second case. So, Dr. Ronak, please start your screen, and
Yes.
let's start with the first case.
Good evening, everyone. May I proceed with the presentation? Is it visible?
Yeah, yeah.
Good evening, everyone.
To
So,
to me, your screen is not visible. Yes. Okay. The first one. Go ahead with the first slide.
sorry, is it visible now?
Yes. Please go ahead with the first slide.
Okay. So the first, going ahead with the first case. So she's a 11-year-old girl who presented to our OPD with epigastric pain since 3 days, which was increasing in severity, dull aching pain, which was not radiating. It was increased after food intake, and this pain is not affected by any change in posture. This is associated with nausea since 3 days and decreased oral intake since 3 days. There is no history of fever, medications like NSAID intake, trauma, liver or any liver disease. No history of eating roadside eatables. No history of jaundice, high colored urine, pale stools, fever and itching. No history of heartburn, nocturnal awakening or water brush. No history of vomiting, abdominal distension or increased bowel sounds. No past history of similar illness or any other member in the family having similar complaints.
So, Dr. Bhushan, with this history, what more information and what do you think the clinical possibility here?
Here, she is a 11-year female who presented with epigastric pain and vomiting. So, if you consider, and it's a acute onset, so duration is also hardly couple of days. So, I feel if you consider the site of the pain and vomiting, we have to give some differential diagnosis for this child on this history. So, as a epigastric pain, we all are commonly we think about it's a gastritis. So, it could be an acute gastritis. The site of pain and vomiting also indicates it could be a acute pancreatitis. Less likely acute cholestasis can present, but there is no jaundice in till now in history. But we can keep as a third differential, and fourth, which is very uncommon in this case, is unicteric hepatitis. As there is hepatitis is very commonly we are seeing. So I would like to keep these four possibilities with this history.
Yeah. Okay. Bhushan. So, upper epigastric pain, we focus on important on the stomach, gallbladder, liver, and pancreas, and the lobes of the lungs. Dr. Ronak, please go ahead with the examination.
So the general examination of the patient, the vitals are as follows: heart rate of 120 per minute, a respiratory rate of 28 per minute, the temperature of 99.4 degree Fahrenheit, with a BP of 128 by 70 millimeters of mercury, with a room air saturation of 98%, with warm extremities and a capillary ripple time of less than 3 seconds. Anthropometrically, her weight was in the +1 standard deviation and height in the 0 to -1 standard deviation, with a BMI of 22.7. Interpretation being a normally nourished child. Going ahead with the systemic examination, on per abdominal examination, on inspection, the abdomen is not distended. On superficial palpation, there is guarding present in the epigastric region. There is no Murphy's sign. On deep palpation, there was no hepatosplenomegaly, no gallbladder palpable. On percussion of the abdomen, there is shifting dullness noted. And on auscultation, the vowel sounds were normal. On other systemic examination, the respiratory system examination revealed reduced air entry on the left side, especially at the bases. However, there were no crepitations or rhonchi. The cardiovascular system examination was normal, and the central nervous system examination, the child was restless, however, still oriented. There was no signs of encephalopathy with a GCS of E4, V5, M6.
Dr. Madhuri, what do you think can be the clinical possibilities? So, how apart from what Dr. Bhushan has said after examination? Yeah, am I audible?
Yes, sir. Audible.
Okay. Is Dr. Madhuri, is she online?
Yes, sir. I am online,
Okay,
sir.
yeah.
Am I audible, sir?
Yeah.
Yes.
Yes, you are audible.
First of all, let me take this opportunity to thank Pakmode sir, Sanjay Deshmukh sir, Vibhor sir for giving me this opportunity and pushing me into this. Sir, like as Bhushan sir has already given us a differential on the history that this could be a possible gastritis, pancreatitis, and maybe some possibility of hepatitis could be there entertained in this child. In the examination, we have seen that this is an 11-year-old child and the heart rate is around 128 per minute. So there is tachycardia and the temperature is a little bit on the higher side, though less than 100, 99 point something degree Fahrenheit. So tachycardia is definitely there. And we also note that the child is actually on the higher side of the weight. BMI is close to +2 standard deviation. So an obese child with tachycardia who is restless and having shifting dullness and reduced breath sound. So there is some capillary leak also going on, or third space losses are also being seen. So that points is probably that whatever condition is there, it's a little bit more serious than mild gastritis or viral gastritis. So we already have a differential being placed in front of us. Acute pancreatitis, we definitely keep in mind because this child has epigastric pain. Probably we need to make a note over here that the classical pattern of epigastric pain, stabbing in nature, improving with the stooping posture may not be present in most cases. So we have to keep a suspicion very high because it's a serious condition. Peptic ulcer disease possible, but it would be a very serious peptic ulcer disease, probably associated with perforation to present with all these signs. And of course, we have seen a few cases of hepatitis A also presenting with capillary leak, something like dengue also coming with ascites at times, but then few would have been present with dengue per se. So hepatitis with ascites seems also to be a probable cause. So the first three differentials seem high on the cards for us that are displayed on the screen, and with a possibility of cholestasis and a very rare possibility of mesenteric ischemia with some blood perfusion of the mesentery going down because of some comorbidities that might be present. So I think we need to be keeping in mind pancreatitis pretty high on the cards with some possibility of maybe anecteric hepatitis and rarely peptic ulcer disease.
Okay. Yeah, nice to sum up. So this patient comes to you in ER. How will you guide your resident in this case?
Yes, so like in this child, as we noted that there is some tachycardia is there, restlessness is there. So probably we need to get an intracath in place and give the child start with fluids. And since gastritis is also one of the differentials, severe gastritis, not just a mild gastritis, considering all the signs that we got, I think acid suppression with proton pump inhibitors like your pantoprazole would probably a good option to start with. And there is nausea. So ondansetron would be a good thing to put the child on, particularly considering that a good oral intake getting established quickly may help in keeping the perfusion. Losses will be kept in check. So yes to an anti-emetic as well. And antispasmodics, we may give it a try if the child is in a lot of pain. Probably we may consider, or we may give some other analgesics to the child, something like maybe an IV paracetamol infusion or maybe a IV tramadol, considering the pain that the child is having. So instead of an antispasmodic, maybe something more specific for the pain, since the pain described was not a colicky in nature. So that would be from the management point of view that fluid resuscitation should be started, considering the child is a sick child with tachycardia, restlessness, and a possible diagnosis of pancreatitis and severe gastritis, and with some volume losses. Probably it's an indicator of early hypovolemia in this child. And yes, we would like to send investigations for this child. We would probably go in with, like, since one of our first differentials was pancreatitis, we would probably go in for a serum lipase and amylase. Lipase would probably be the better one. And for some hepatitis or coexisting hepatitis, we will go in for the liver enzymes. And of course, an ultrasound of the abdomen to look for the pancreas, the liver, free fluids, any complications. So ultrasound would be a very good investigation to go in this child after stabilization, or a bedside ultrasound.
Okay, ma'am. So this child was investigated. The routine investigations are as follows. Child had an HB of 9.7 with a total leukocyte count of 20,000, which was predominantly neutrophilic with 77%. a platelet count of 5 lakh, and on the peripheral smear, the child had hypochromic microcytic anemia. The liver function test revealed total bilirubin of 0.9, the direct component of 0.2. The hepatic enzymes of SGOT and SGPT were 62 and 59, with a total protein and albumin of 7.3 and 4.0. And the renal function tests revealed a BUN of 16 and a creatinine of 0.6. And the electrolytes were within normal range, sodium of 137 and a potassium of 4.1. The pancreatic enzymes were elevated, where the serum amylase was 837, which is quite high compared to the reference range of 0 to 260, and the serum lipase of 1335, which was again quite elevated compared to the reference range. Along with that, the serum calcium and the serum triglycerides were within normal range. So,
Yeah. So if you go through this, with the previous, can we show the previous slide?
yes.
So if you go through this investigation chart, as we have kept clinical diagnosis as acute pancreatitis as a first differential, you can see in a CBC there is a leukocytosis. So the total WBC count is 20,000. Okay. Then along with that HGPT, if you consider with the liver function test, there is a OTPT has marginally increased. So we are dealing marginally increased. We can get it in some viral infections also. So that's give some clues with some inflammatory markers. That is leukocytes is high and significantly raised amylase and lipase. The amylase and lipase is more than 3 times of the normal, that we consider it is a directly involvement of the pancreas. So these all three things go in the favor of this is a case of acute pancreatitis, probably viral origin. So it's the first thing. In some cases, there is some cases where we get acute exacerbation of chronic pancreatitis. Specifically, if the patient is a known case of pancreatic divisum, or he was a hereditary pancreatitis, or some mutational diseases. So that recurrent pancreatitis, they can have similar picture. So we can keep as a second thing. Only thing is the if it is a chronic pancreatitis, amylase lipase we might not be getting such a significantly raised. So that's why we keep it as a second thing. So probably it look like to be acute pancreatitis. Severity, this depends on the count. So we'll see. We have next few slides.
So, the definition for acute pancreatitis in the pediatric age group, according to the INSPIRE criteria, which is the International Study Group of Pediatric Pancreatitis in Search for Cure, the definition acute pancreatitis is defined as at least two of the following. The first is the presence of abdominal pain, which is compatible with acute pancreatitis. Second, a serum amylase and or serum lipase more than equal to 3 times the upper limit of normal. And third is imaging findings consistent with acute pancreatitis. So, discussing the pathophysiology of acute pancreatitis.
Pathophysiology of acute pancreatitis is very clear. I think most of us are we are known. So it's or any infection, trauma, ischemic injuries, drugs and toxins, obstructive or secondary to bile stones or bile reflux, some metabolic disorders. These all will cause some pancreatic stimulation or pancreatic injury. Once that pancreatic injury started happening, it will cause conversion of trypsinogen to trypsin, and there is a enzyme activation. So release of trypsin and enzymes like protease and in the system, that will cause problematic things. So that depends on how severity of it is. So it involves first with the local pancreas is definitely directly involvement. So we get pancreas, we can have edematous pancreas, inflammatory pancreas, we can have hemorrhagic pancreas, and we can get a necrotic pancreas. So that's why it's called the acute interstitial edematous pancreatitis or acute necrotizing pancreatitis. Simultaneously, will have some localized, so peritoneum and peripancreatic involvement. Specifically, it is depends on there is a pancreatic fluid leak which will cause abscess, thrombosis, ascites, fatty necrosis. These are the few presentations if it is related to the peritoneum involvement and peripancreatic. Here we get a gastroparesis, or we have some ileus like picture also. So, and then third thing is involvement is a WBC activation. That is a systemic inflammatory response picture. Like, so it is because of high leukocytes count and monocyte stimulation. So monocyte stimulation leads to release of interleukins like the 168, then platelet activating factors, and so leukocytes will cause release of protease, elastase, and free radicals. And all these three will cause tissue destruction, then directly, or they will cause organ failure. Leukotyne itself is a leading to organ failure, and third is a endothelial injuries and neutrophilic activation. So all these are the systematic inflammatory response syndrome like picture, which will finally at the will leads to the organ failure. So involvement of organ like kidneys, lungs, pulmonary involvement, cardiovascular involvement, shock. All these are the severe indicates it is a severe condition of pancreas. So the if you that's why the pathophysiology we should think about what which is if what's a part of the body is involved. So it we can able to grade is it mild pancreatitis, or is a moderate pancreatitis, or moderately severe pancreatitis, or severe pancreatitis. So that's why we should know the pathophysiology of acute pancreatitis. There is a if you see the course first week, and so first week is a early phase of the pancreatitis, usually over by the end of the first week. It is very milder form. Child has like our picture. Suppose this the current case, we can see it is the first week of presentation. There is a there is no signs of shock and there, so there is no only fever is there. So if there is a characterization of inflammatory markers like systemic inflammatory response syndrome, tachycardia, high temperature or hyperthermia or hypothermia, high leukocyte count or low leukocyte count, tachypnea is there or not. Then determine that will indicate any signs of determinant of severity. So if it's still there is a progression to the presence and duration of organ failure. So if you consider first week is a milder, then it will further leads to exercise, then multi-organ dysfunction, and it could leads to the death.
Excuse me, ma'am. Vibhor sir is not unable to unmute himself. So, can the host please?
I think you can go with the left. This is a late response of acute pancreatitis. So late response is also similarly what I told is a pathophysiology. So persistence of any systemic signs of inflammation or by the presence of any local complication will aggravate the disease, and it is occurs only in a moderately severe or severely acute pancreatitis. This is along with the local complication evolves over time. So if you see the second week is very crucial time for the acute pancreatitis. There is a leading to extensive pancreatic injury. It will cause infected necrosis, sepsis, again SARS, and multi-organ dysfunction and death. So second week is a high period. First week is a golden period where if you intervene in time, we can prevent such a future complications. So that's why I think we think about acute pancreatitis.
Hi, is Vibhor sir back?
Yes, ma'am. Sir is there, but sir
Yeah, yeah. Hi.
Yes, yes.
Yes. Okay. Excellent summary. I think why we keep this slide is because to uh, basically manage pancreatitis, very understand to what is the pathophysiology and how it differs in the first week and second week of illness. So we calculate it from the onset of symptoms rather than the admission, and depending on that, we will manage. So, Dr. Madhuri, so how do we have seen the definition, pathophysiology. Now, how do we grade the severity and then how it affects the further?
Yes, sir. Like in this child also, we've got like this child is present with 3 days history. And so it's already 72 hours for our child. And based on the severity for this child, like there's tachycardia. So we may say that hemodynamic instability is there. So we've got a clinical severity grading for acute pancreatitis as it's displayed on the screen as per the revised Atlanta classification of 2012. So mild acute pancreatitis, no organ failure. So organ failures would be a circulation, your kidneys, your lungs, those would be a systemic organ failures, which will be which will be taken up later. Then no local or systemic complications, and this will usually resolve in the first week of the illness itself. So it's something that we can beautifully manage in the first week, and we would probably not want it to progress to the moderately severe acute pancreatitis. So if we catch them in the golden period of first 24 to 48 hours, maybe we can make a difference. So the moderately severe acute pancreatitis is transient organ failure that resolves within 48 hours, and or local or systemic complications without persistent organ failure. So some organ failure might be there, but it usually resolves within 24 hours. Whereas severe acute would be something that organ failure is persisting beyond 48 hours, or a single or multiple organ failure is present. So clinical grading is based on the presence of organ failures and some local or systemic complications. So that would be guiding our like severity grading clinically.
Okay, so which organs basically we will look at?
Yes, so it was coming in the later picture, sir. Could we can we go it at that time, or we can take it right here?
Okay, good, fine, well, we can take it later. Okay, so next slide please, Raunak. I'll just keep, so these are the common causes of acute pancreatitis. Most of them are idiopathic. Sometimes it can be a first episode of the recurrent pancreatitis as well. And infections, viral infections are another second most common cause of the acute pancreatitis. But it's very important to rule out any drugs, any obstructions. Okay, then the systemic illnesses, they do cause pancreatitis, but the severity is not that great. Okay, next slide, Dr. Yeah, so these are the common causes in Indian series. Okay, next slide. So let's go to the management. We will discuss in detail. Go to the next slide.
Yes, sir.
So about the Ronak can summarize what importance of amylase, lipase, what happens. Don't spend a lot of time here.
Okay. So the elevated amylase and lipase, which is typical of acute pancreatitis, these are the general pharmacokinetics of the two enzyme activities. So serum amylase usually can be elevated in the first 2 to 12 hours compared to serum lipase, which is around 4 to 8 hours. Important to note is that the duration of elevation, serum amylase usually remains elevated for 3 to 5 days, whereas serum lipase remains elevated for 7 to 14 days. This longer duration of elevation of serum lipase is useful in cases with delayed presentation. Other than that, the sensitivity and specificity of serum amylase is 78 and 95%, whereas serum lipase is a little bit better, 86 to 100% and 95 to 100. And lipase level.
Go to next slide.
Yes.
Go to next slide.
Okay. So, however, there are serum amylase and lipase elevation are usually not specific for pancreatitis. There are multiple conditions associated, as we can see. So serum amylase is elevated in multiple GI causes like appendicitis, intestinal obstruction, peptic ulcer disease, biliary tract disease, and celiac disease and IBD, and other conditions like salivary gland infection causing increase in the salivary amylase levels, and other multisystem involvement like pneumonia, diabetic ketoacidosis, acute kidney injury, burns, and acute liver failure. And serum lipase as well are seen in elevated in certain GI conditions like acute cholecystitis, intestinal obstruction, and celiac disease and IBD, and peptic ulcer, and other conditions like diabetic ketoacidosis, acute kidney injury, and hyperthyroidism.
So the elevation is not specific even for lipase. So mild elevation can be associated with n number of GI conditions. So just elevation of amylase lipase is not pancreatitis. Okay. Yes, Dr. Madhuri. So what is the role of ultrasound? When to do and how to utilize it? Yeah, I think the setting is if you mute yourself, it becomes difficult to unmute. So I think speaker, let's not
Yes.
mute yourself.
Okay, sir. Like I'm sorry, I just went about it. So in this child, like we already have a clinical suspicion of acute pancreatitis, and ultrasound is the modality for confirming the presence of pancreatitis as a diagnosis. So that it would serve first the purpose is to get some bulky pancreas, maybe some peripancreatic fluid is there, ascites is there. All those would be pointers towards a pancreatic inflammation. So ultrasound as a baseline modality to diagnose acute pancreatitis. It may also detect any etiological conditions like a gallstone, a stone on the CBD, maybe some previous evidence of any pancreatitis, calculi, any evidence of hepatitis. All those things would be visible on an ultrasound. And we can also the complications or severity based upon pleural and peritoneal collections as were present in our case. It would also help with that. So for diagnosis purposes, ultrasound in the first few days, particularly in the first 3 to 4 days of the symptoms, may be the best thing to diagnose acute pancreatitis. Not a very good entity or not the best possible thing to maybe detect complications. For that, probably a different imaging would be more useful.
Yeah. Okay. Yeah. And what is the role of hello? Am I
Yes, sir. Yes, sir.
Yeah. So in the index case, there was a bulky pancreas, there was a grade 1 fatty liver with mild hepatomegaly, and there was left side pleural effusion and moderate ascites. Next slide, please. So what is the Dr. Madhuri? So how do you utilize the CCT? What is the right time to do a CT?
So, as we said, maybe for diagnosis, first few days, ultrasound, and for complications, CT would be a modality that we would look for. So, if you are anticipating that this probably child is having some necrotizing pancreatitis, some collections are there, in those scenarios, probably a CCT would be warranted. So, non-resolving symptoms, increasing symptoms towards the second week, a new onset fever, abdominal pain, vomiting, in a child who's been diagnosed with acute pancreatitis, you're suspecting it's got infected, probably you need a CCT at this point of time. So as we've already displayed in the slide, early imaging, it may not give you an idea whether there are any complications or not. So it won't serve the purpose. You're unnecessarily shifting the child and probably not getting the returns that you want. So it should be probably delayed beyond 72 to 96 hours if you need it. So if there is clinical deterioration or a persistent condition, no improvement after 48 hours, then you should consider getting a CCT done to look for pancreatic necrosis, any complications like a wall of necrosis or something of that sort, and an etiological possibility which has not been detected by your ultrasound like a gallstone or a biliary disease or some anatomic abnormalities. So that would probably summarize the role of CCT, not to be done probably in the first few days, no returns on it as such. If you're suspecting complications, a severe pancreatitis, you go in for a CCT after the first 3 to 4 days of these symptoms.
Yes, and as we have seen pathophysiology, there is a significant surge, there is hypovolemia. So
Yes.
giving a contrast can aggravate acute kidney injury as well. So the index case, there was mostly a edematous pancreatitis. It was non-necrotizing, and there was ascites, and there was a small eccentric thrombus at the portosplenic junction. Okay, next slide, please. So, Dr. Madhuri, how does the CT scan, the scoring, it helps?
Yes, so as we see here display, look, we had the clinical severity for acute pancreatitis, and now we have a CT imaging to maybe guide us in how this child is going to behave. So as you see that we have scored it based on two things. One is like evidence of any inflammation of the pancreas and necrosis score. So these two together, like grade A is a normal pancreas, 0 score. B is just focal diffuse enlargement without any other peripancreatic inflammation. So the score is going from 0, 1, 2, 3, 4. Grade C would be with some peripancreatic inflammation. Grade D is associated with a single fluid collection, and E with more than 2 or with gas in the pancreas. So this is the grading. Plus, if you've got necrosis, like up to no necrosis, a score of 0, up to 1/3 of the pancreas is necrosed, it will be a score of 2. 1/3 to 50%, 4, and more than 50% would be 6. So you add these two together and you get a maximum score of up to 10. Now, what, as we see it displayed over here in the slide, we have up to, when the score is less, the cutoff can be around 6. So 0 to 6, the chances of death are 3.8%, 7 to 10, the chances of death are around 18%. And as we are seeing down, the negative predictive value is better than the positive predictive value. So if you're having a score which is less, probably it tells you that this child is having less severe or a mild pancreatitis. So no presence of severe pancreatitis. So we can actually use to prognosticate if the score is less, it's probably a better indicator that it's a mild disease. It may not be totally like correlating. The clinical picture may not correlate with the CT picture.
Yeah, so one type of severity we have seen the anatomical one, that's on CT. So clinically, Dr. Bhushan, what are those organ failures which will decide that, okay, the patient is going towards moderately severe and needs an ICU management?
So, if there is a signs of systemic inflammatory response syndromes like tachycardia, as I initially said, there is a tachycardia, persistent fever, hypotension. These are the features which is favors the child is going in a severely form. Simultaneously, along with the involvement of organ failure like cardiac, if there is a hypotension, the pulmonary for pulmonary, if there is a ARDS like picture, like the PaO2 is less than 60. A renal injury is there if the creat is rising, there is a oliguria, that indicates there is a renal shutdown, and GI blood losses. So because of the thrombosis or because of this systemic inflammatory markers or cytokine storm like picture, which will leads to severe blood loss picture or DIC like picture leading to GI blood loss. So if these are the features are there that indicates patient is deteriorating, there is a severely patient is in a severely involvement of the pancreas, and in presence of complications, as the madam has said rightly said, if there is a severe CT score is high, which is showing ward of necrosis is very poor prognosis, or it has a we need an intervention in that instead of only edematous pancreas. So if a presence of ward of necrosis, if there is a fluid collections like formation of pseudocyst or increasing size of pseudocyst, ascites, these are the few predictors which indicate this a child is having a severely going in severe pancreatitis.
Yeah. So we'll skip this slide of complications. So most important is GI loss is not seen that commonly, GI blood loss, but hypotension, desaturation, or AKI. If anyone should get, that's either severe or moderately severe pancreatitis. It persists more than 48 hours, it is severe. So if you are getting any of these things, then you decide about admission to an ICU or what. Otherwise, mild pancreatitis can be managed in the ward or even at the home on OPD basis as well. So go to the management slide. Yeah. So the management of acute pancreatitis, basically most important is hydration, as we have learned in pathophysiology, then analgesia, then monitoring for complication, and the early enteral nutrition. So next slide. Dr. Madhuri, can you just explain like how this fluid management in first 48 hours is important in the management in the acute pancreatitis?
So like this beautiful diagram that Dr. Ronak has put in with Dr. Vibor's guidance. So we've got in the first picture, we've got a normal pancreas, it's doing well. And you've got the hit in the form of acute pancreatitis. You can see that because of the inflammation, because of the vomitings, you're getting volume losses there. Because of the pain, there is all respiratory efforts are there. You're losing water through that. There is sweating. Because of that, you're losing it in the peripancreatic fluid if it is a more severe thing. So overall, it's landing up with hypovolemia. So the acute inflammation is making the child go into hypovolemia. Vomitings is adding to it. Lack of fluids because of nausea will again to add to it. Now to like this part, if we intervene in the first 24 to 48 hours, like most cases, like in the literature, if we see that most cases of pancreatitis, whether they are severe or moderately severe or mildly severe, they all come in the initial stages as mild. So what makes difference probably is how you manage them in the first 24 to 48 hours. So this is what may happen. If the child is not well managed, you look at the third pancreas picture. So the child has hypovolemia, and what has happened to the pancreas? It's got ischemic changes in the pancreas due to decreased perfusion. So you've got hypovolemia, the kidney is getting hit, because of which the perfusion to the pancreas is going down. It is getting ischemia, and now you've got a second hit to the pancreas, like first primary inflammation, and now because of the ischemia, and you may land up with a necrotizing pancreatitis, which may further add on to secondary infections as well. So if we intervene in this first initial period when the child has losses, but the perfusion to the pancreas is probably as of now not affected, and we perfuse the child adequately, probably not waiting for it to get hit. Like in this child, the BUN is about
Next
60.
slide.
So the whatever organs are there, they're still normal. So if we take care of them at this stage, probably this child is likely to remain in the mild acute pancreatitis and get over by a week's time, rather than land up with moderate to severe. So the first 24 to 48 hours are crucial, and if we act at that time, probably we may be able to prevent or lessen the severity of all our pancreatitis cases. Should I go ahead?
Yeah, fluid. How to give fluid? Yeah.
Yes. So this is one concept. It's thanks to Vibhor sir to putting him that I also went through the literature. The reference that Dr. Ronak has given, it's given one of the studies that is there in March 2024. Role of moderately aggressive intravenous hydration. So within the first 24 hours, it decreases both morbidity and mortality due to acute pancreatitis. Even if there is no hypovolemia, so if this child is having mild tachycardia is there, even pulses are like not that low volume, his blood urea creat is still normal, his normal saturations, so apparently end organs are looking okay except for the tachycardia, maybe we still, it's a good idea to resuscitate at a rate of 1.5 to 2 ml per kg per hour. And if there is hypovolemia, like this child may be having, like we may say that this child is having mild hypovolemia. So if you feel that there is hypovolemia because of signs of failure like tachycardia, poor pulses, maybe a narrow pulse pressure, all those things, then you may consider giving a bolus of 10 ml per kg. So resuscitation in the first few hours, even when your end organs like BUN creat is normal, you probably keep it normal by giving a little bit aggressive fluid resuscitation. So that is one. So even if the child feels okay, you maybe give it a fluid rate of around 1.5 to 2 ml. If it is normal, if it's hypovolemia, give a bolus. The second thing that is mentioned on the slide as it's displayed is role of ringer lactate as compared to normal saline. So ringer lactate is also containing calcium, which probably keeps the non-esterified fatty acids bound and prevents further injury to the pancreas. The lactate prevents, it reduces the inflammation. Yeah. And normal saline is more acidic, may cause more problems with the non-anagap hyperchloremic metabolic acidosis. So there are a few studies which are showing distinctly a little bit more in favor of lactated ringer lactate as compared to normal saline. If in acute pancreatitis, we go in for that. And as we have mentioned here, we target BUN, creat, and urine output, and early assessment at around 6 to 8 marks, 8 hours.
Yeah. Very important information. So pain management is standard. Let's go to next slide. So two more important concepts quickly, and then we'll move out to the next case. So the role of antibiotic. Bhushan, quickly, what is your recommendation in this?
Definitely. So there is a no role of antibiotics. So prophylactic antibiotic is not recommended. We should not start. There is a few indications only where we can use antibiotics if the patient is in a second week of pancreatitis, or if it's having infected necrosis, necrotizing pancreatitis like picture, is not improving clinically, then we can consider about antibiotics.
Yeah. Yes. So prophylactic antibiotics, no role if the patient is very sick, like moderately severe, and requiring any invasive lines, then we are giving more for that. But mild pancreatitis, no antibiotics are required. Excellent. Okay. Next slide about the nutrition. How aggressively we should be educated. Just 2 lines quickly.
First, most important is early oral feeding. So early feeding within 24-48 hours is strongly recommended. It prevents the so many complications like decreases cytokine storms, decreases incidence of gastroparesis on. So we have to start oral feeding. We usually keep NPO for maximum 24 hours to 40 hours and start enteral feeding. To go with the enteral feeding, you can start by the nasovaginal or nasogastric, doesn't matter. You have to start the feeding because there is a efficacy same for the root. type of food, we clear feeding versus low fat soft diet. So there is also equally efficacy. So the aim is to start early feeding. So preferably go with the clear feeds to begin, and then go with the low fat soft feed. Semi pet has no any
Yeah.
extra
So yeah,
benefits.
yeah. So contrary to earlier belief that if you start a nutrition that and early nutrition. These are the two important advancements in the recent understanding. So let's keep these slides because these are like special management. So I think in the follow-up, Dr. Rauda, can you tell us how the child is doing now?
Yes, sir. So the child was admitted with us 1 month back. So in the next OPD visit, child does not have any pain. There's no clinical symptoms. Able to eat well and is vitally and clinically stable. So we have kept the child on close follow-up now.
So he was moderately severe and recovered, right?
Yes, sir.
Yeah. So yeah. So so how many minutes we have for the case two, ma'am?
We have
Suppose
10,
you
sir.
can you can do in next 20 minutes, no problem.
Okay, sure. So yes, Ronak, go
Yeah.
ahead.
Okay, sir. So the second case is that of an infant presenting with neonatal cholestasis. So she's a 2-month-old girl, second by birth order of non-consanguineous marriage, has presented with jaundice since the second week of life. Incidence onset noticed by the mother, progressively increasing. This was associated with persistent ambiguous stools with high color urine, associated with mild abdominal distension for the last 2 weeks, which was more in the upper quadrant. Associated with this, mother complains of poor weight gain during this period. This jaundice was not associated with fever, vomiting, irritability, or itching, not associated with lethargy, convulsion, or altered sensorium, no bleeding like hematemesis or melena. There was no similar family history and no history of perinatal complications in the child. The ANC history was unremarkable. There's no history of fever with rash, no history of gestational diabetes, hypothyroidism, or itching during pregnancy. Birth history, child was full term, normal vaginal delivery with a birth weight of 2.7 kg, no NICU stay. Child was immunized up to date and developmentally appropriate and exclusively breastfed. So on examination, the child had a heart rate of 128 per minute, the respiratory rate of 32 per minute. Child was afebrile with a good room air saturation, and extremities were warm and capillary fill time was less than 3 seconds. Icterus was seen. There was no facial dysmorphism noted. Anthropometrically, the weight for age was less than -2 standard deviation, the length of less than -1 standard deviation, and a head circumference of less than -1. However, the weight for length was less than -3 standard deviation, giving the impression of failure to thrive. On systemic examination, per abdomen examination on inspection, the abdomen was distended. However, there was no prominent abdominal veins. The umbilicus was pushed down and was transverse in nature. On superficial palpation was soft, and deep palpation, the liver was firm with 3 centimeter below costal margin with sharp borders extending up to the epigastrium with uniform margins with a liver span of 7 centimeter, and a left lobe was palpable, which was firm with 1 centimeter below sulfide. A spleen of 3 centimeters was palpable, which was firm and grade 2 splenomegaly. However, on percussion, there was no dull note or no ascites, and the bowel sounds were normal. The rest of the system was normal. There was no cardiac murmur or anything.
Okay, so Dr. Bhushan, so what next? What are the important information you will focus when the child is having this neonatal cholestasis, and how will you use this information as in a clinical algorithm?
So first important thing is कि if there any child, 2 months child, so who is presented with a jaundice, dark colored urine, and pale color or white color stool, along with hepatosplenomegaly, and non-sick child. So it's a very so these are the few points where we give some clues about whether the child is sick looking or not sick looking.
Next slide. Ronak.
Yes.
And we have to reassess the color of the stool also. So even if the parent said it is a yellow color, I think being a doctor, we should directly check the exactly what is the color of the stool. It will give very good idea about the cholestatic pattern. There is a stool color chart. I think physicians should observe the stool color themselves for 3 consecutive days. That is also important, and counsel the parents to keep the tracks of stool color according to chart. We are making having a policy suggestion that incorporation of infant stool color card to Indian mother and child protection card. So coming to this approach to the neonatal cholestasis, this is very well published in the Indian Pediatrics. We can see if the child who comes with a jaundice, dark colored urine, with or without alcoholic stools, with a hyperbilirubinemia, serum with a raised urine bilirubin and serum bilirubin. Our first aim is to give vitamin K stat, irrespective of what is the cause, and then we have to consider specialty centers and other liver function tests and assess the clinical condition. Important part is the whether child is sick looking and not sick looking, because if the child is sick looking, that indicates child has a refusal to feed, child is drowsy, child has a history of convulsion, that all is indicates child is sick looking. So that goes in the favor of something metabolic causes of liver disease. So in that case, we more consider about metabolic causes. So we investigate in the form of like urine for reducing sugars for galactosemia, blood and urine culture for sepsis, any malarial parasitic infection, torch group of infection. These are the sick childs. Urinary succinyl acetone for tyrosinemia, serum ferritin for neonatal hemochromatosis. So these all are the childs with a sick child. So if the child who with a not sick, that is how our child is there. Our case is with a not sick child. So in that case, you look for the pigmented stool and pale, non-pigmented stool. If the pigmented stool is there, they consider about the ultrasonography and liver biopsy for further investigation. We consider non-biliary atretic conditions like PFICs are there, Alagille syndrome, that they can present with the pigmented stool. They are not sick looking and pigmented stool. If they are pale stools or non-pigmented stools, then you consider about the few investigations to rule out biliary atresia. That is, it is a very right time. On the day one only, we have to, if the child is fitting with all this clinical finding, if you are considering biliary atresia, do the same basic investigation like ultrasonography and liver biopsy. Liver biopsy is a gold standard investigation for the diagnosis of biliary atresia. In plus minus HEDA scan.
Yeah.
So here in our
So
case, I think we can keep this few differential like biliary atresia, child with a choledochal cyst, less likely, or inspissated bile duct syndrome. It is also one of the rare, but it can be as a differential diagnosis.
so these are probably the other clinical
Are we timed out?
No,
No, we are not.
okay.
We can continue.
Okay. So these are the red flag signs that should be considered in a neonatal cholestasis syndrome. So the viewers can take a screenshot of this. Each of these red flags can direct us towards the individual diagnosis of neonatal cholestasis. So over to ma'am.
Yes, so as in this case, we made a clinical syndrome of neonatal cholestasis based on the urine color and the stool color and the hepatosplenomegaly that we had. So we would want to have a total bilirubin along with the fractionated bilirubins to start with, to know like what to confirm that it is cholestasis. Then liver enzymes, alkaline phosphatase, very essential gamma glutamyl transpeptidase, which will help us to get to these things. And to know the liver synthetic function, we also want to do a total protein albumin and PT-INR. We usually will judge it about after vitamin K dose after 6 to 8 hours, whether we have a liver failure or it's just a cholestatic component that is there. So at one time, we want all the liver parameters to be tested at least once to get an idea.
So in this index case, the CBC showed a hemoglobin of 9.2 and a total leukocyte count of 15,000, and with a normal platelet count. And the renal function test and electrolytes were normal. In the liver function test, the child had a total bilirubin of 9.5 with a direct component of 5.8. with a elevation of the liver enzymes in SGOT of 195 and SGPT of 81. The total protein and albumin albumin was not very low, the 3.4 of albumin, with a prothrombin time and INR of 17.2 and 1.5. The ALP was 746 and the gamma glutamate transferase was typically high for age, 192.
So as we can see, this child did have a direct bilirubin component, which is high. The GGT was also high, and there was a mild elevation of the liver enzymes were there, with INR just sitting on 1.5. So we have the definition of neonatal cholestasis displayed on the screen. The first is what we have read, like all of us at my during my residency were taught, the neonatal cholestasis definition of 20% of the total if the direct bilirubin. But what we want everyone to go back with is what is being repeatedly told now is that any elevated serum direct bilirubin, a direct bilirubin level of more than 1 milligram per DL, it warrants timely consideration for evaluation. So we should probably keep a watch all our neonatal jaundice cases who are having jaundice. If they have a direct bilirubin component of more than 1, we probably need to be alert. Maybe we are thinking the total bilirubin is around 15, 20, and direct bilirubin is 2 or 3. Still, please keep a watch that this bilirubin has come down to, direct bilirubin has come down to less than 1 when you reassess this child, because these children can actually be showing you markers of cholestasis right from the start. So a direct bilirubin level more than 1 milligram per DL, please keep a watch, refer this child if required at the earliest. So going further with the algorithm, like as we said, we probably want to get an ultrasound in this child as well. Ultrasound gives us clues about a lot of things in a child with neonatal cholestasis. Now, this baby was a non-sick baby with a pale stool. We want a fasting ultrasound because the gallbladder we are expecting physiologically will distend with fasting of up to 4 hours if tolerated by the baby. If we get a normal in biliary atresia, you may get a normal gallbladder. So please remember, normal gallbladder could also be a biliary atresia. You may get a small gallbladder that is probably more easily pointing towards a diagnosis of biliary atresia, less than 1.5 centimeters length. Absent gallbladder, we're very happy. It's very giving us a nice clue. And choledochal cyst, probably it will straight away require a surgery. So, and we also have like pre-feed gallbladder volume, post-feed gallbladder volume. So you're fasting the child, gallbladder is distended, you're feeding the child, the gallbladder is seen contracting, the volume is changing. There is a formula also given that if you get a good contraction, maybe you can say that biliary atresia is unlikely. So ultrasound may give us some clues definitely about a diagnosis of biliary atresia, and that's our first priority in a child with otherwise well child, non-sick child with cholestasis. We want to rule out biliary atresia. Preferably, if the child comes early to us, this is the time we should not miss it. So again, in gallbladder, you can ask the radiologist to look at these signs. When you write a requisition for ultrasound and you're suspecting biliary atresia, please write, look at the liver echo texture, tell me the length of gallbladder. So if less than 15 would probably be suggestive of atresia. A smooth mucosal lining goes against, irregular ones is going in favor, and you've got the contractility index. So if you've got a good contractility index is present, then probably the gallbladder is emptying out well. So you can guide your radiologist to give you some clues. So these are the classic things that are described in biliary atresia, a small and irregularly shaped gallbladder that we are seeing over there. Then what we have learned during our residency, a triangular cord sign, which may or may not be present even though it is biliary atresia. But if it is present, it may help it further. And sometimes you may get like the spectrum of biliary atresia and choledochal cyst. You may get an intrahepatic cyst also along with it.
Okay. I think I'll go with
Yes.
this.
Yes, you can proceed.
Proceed. As after the ultrasonography, I think most of our pediatricians we consider what is a diagnostic test for the biliary atresia. So we always most of the them suggest HIDA scan, but as I want to say the HIDA scan has a very less specificity. So it hardly 33 to 90% has a specificity as compared to liver biopsy. And there is a radiation exposure, cost and delay in care are major drawbacks of HIDA scan. So HIDA scan, if you want, it is used to rule out biliary atresia, but not to diagnose the biliary atresia. That is a very good message we want to give with this media. So go with the liver biopsy. It is a gold standard to diagnosis of liver biopsy. It helps you lots in many ways. It's a single most definitive investigation at a very good sensitivity and specificity as compared to HIDA, accuracy of 60 to 95%. Percutaneous liver biopsy in early infancy can do under local anesthesia if it is safe, and also it's useful for the diagnosis of other specific conditions like Alagille syndromes and all. So if you sending and doing liver biopsy and sending sample to the pathologist, I think we need some discussion with the pathologist because most of them are not aware what to see in specifically to in a neonatal cholestatics. Ask them specifically to look for the what is the size of the ducts, what is the number of the ducts, then look for the ductular proliferation. So it is more ductular proliferation, bile plugs, and portal fibrosis. These are the best indicators. Which, if it is there, which is a indicates it's a clear-cut case of slides of biliary atresia. It's a, so further investigation, I think Madam will
Yes,
continue.
madam.
Yes, sir. So this is just a comparison of like to diagnose biliary atresia, there are the three modalities that are commonly we are traditionally been practicing: an ultrasound, a percutaneous liver biopsy, and a radionuclide scanning. That is our HIDA scan or like a hepatobiliary scan that we are having. So as we can see, the sensitivity for obstruction, it's probably a little bit variable, but you're getting high sensitivity across all the three modalities. But what is more important is the specificity that we are getting is probably like considering the best possible in these three would be a liver biopsy. It will help us to diagnose like extrahepatic biliary atresia, as well as other diagnostics can also be made. So probably for obstruction, biopsy would be the best modality. Ultrasound can give a clue, and HIDA will probably rule it out in whom you're not suspecting. This is intraopical angiography, so gold standard for diagnosis of biliary atresia. So there is no evidence of bile flow in extrahepatic biliary tree. It confirms the diagnosis of biliary atresia. And if it's a child who has not had cirrhosis set in, probably we can go in for a portoenterostomy in the same setting, hepatoportoenterostomy, and probably maybe we give some good many years to the child with a native liver. So again, we can, during the intraoperative procedure itself, we can do a frozen section with a biopsy, and the same things that Bhushan sir has already mentioned, the classic signs of biliary atresia: bile ductular proliferation, bile plugs, and periportal fibrosis. We may get that.
Yeah. So, Dr. Bhushan, like, how is this? Like, what is the basically ideal age of doing all this?
So as the patient comes to you, if you are suspecting biliary atresia, do they, if possible, IOC or come to the diagnosis and go for the Kasai. As in previous slide, they mentioned, if the IOC is positive, if there is no dye, we go in that time only you go for the Kasai surgery, because Kasai has a good efficacy if you are doing it in early. So outcome rate or success rate is depends at what age you are doing. So if it's less than 1 month, 90 to 95% has a success rate as compared to more than 100 days child. So 80 to 100 days we get 20%, more than 105%. So I think age we have to do our early diagnosis of biliary atresia and go for the Kasai as soon as possible. That's why we are skipping HIDA scan. Do not waste the time on doing investigations. Then we'll once your diagnosis of neonatal cholestasis, non-sick child with a USG and suggestive of biliary atresia, go for the biopsy, get it done. Then if it is in the favor of biopsy, if your biopsy is in the favor of cholestasis without any cirrhotic changes, you can definitely go with the Kasai portoenterostomy. If there is a cirrhotic changes is there, or liver is badly involved, severe fibrosis with a decompensated picture on LFTs, then that child that straight away go for the liver transplant. So it will go. We can go ahead with the such a involvement, surgical planning.
Okay. Yes. Madhuri, so when we say, okay, so successful, and what are the causes of failure?
Yes, so probably if the baby has passed pigmented stools within 3 to 5 days of doing the procedure, that would be one. And the jaundice falling in a time of around 3 months by 3 to less than 3 milligram per DL, that would be probably considered a successful Kasai. And we're always worried about a lot of ascending cholangitis. So since we have connected the small bowel to the portal tract, there is always a risk of cholangitis, which may be one of the main contributing factors, stenosis of the anastomosis. And since we all know that biliary atresia is a progressive fibroinflammatory condition, you may get progressive loss of intrahepatic bile ducts, which may be one more cause causing failure of a Kasai.
Okay. When do you do liver transplant?
So like if like we
Is
got
for the time. So generally it's a late presentation, unfavorable. Yeah. So unfavorable presentation, late presentation, refractory growth failure, Kasai, uh, coagulopathy, then we do go ahead with the liver transplant. Now, the less than 2 months, definitely Kasai. More than 3 months, definitely liver transplant. Now, to 6 to 90 days, if you see the success rate that Dr. Bhushan, it is 50%. It's as good as tossing a coin. So 50 to 90 is very debatable, and that's what should we do at this time. Okay, so next slide. So this was the last. So this child has a successful Kasai. Supplement that should be when you diagnose neonatal cholestasis, and that till the cholestasis resolved. Okay, yeah. Next slide, please. Last slide. This is just the learning points in both these cases. We can take the question time for discussion. So, hello.
You're audible, sir.
Yes, sir. Yes, sir.
Yeah. See the chat box. If there are any questions, I have logged out multiple times. I can't see all the chat box. So you see, if there are questions, we can take the questions, if time permits. Madam, can we?
Ron.
Schedule now.
Before we can take the questions, we can stop the screen share.
Yes.
So we have one question. Somebody's written they would like to hear something about pseudocyst of pancreas, its clinical suspicion. Can we take that question, sir?
Yes, yes. Yeah. So, yeah. Anyone, Dr. Bhushan, Dr. Madhuri, will you like to comment on this?
To intervene, I think for pseudocyst, I think we should follow the rule of 6. So any pseudocyst of more than 6 centimeter and more than 6 weeks affecting the stomach, then we consider about cystogastrostomy for that condition.
Okay, sir. The next question, I
The
think, so
next
regarding the
sections,
first
when they
case.
organize.
Please continue, sir. Please continue.
Please go ahead.
Yes, sir. The next question is, till how long should we give fluids at 2 ml per kg per hour? This is, I think, pertaining to the first case, treatment part.
Yeah. Yeah. So guidelines mentioned are for adults. What we do explain pediatrics, as Dr. Madhuri has mentioned, on the first day when you are physically seeing the first, you start around 1.5 maintenance. So there is a there we give bolus. But the total fluid in the 24 hours not be more than first 24 hours. Next 24 hours, you maintain the normal volemia by giving the normal maintenance. Now, once the first phase is over, then there are more to give a fluid. give more description?
I think we have lost her. He got disconnected.
Yeah, anyone, Madhuri or Dr. Bhushan can take up.
Yes, so like the fluid management, as sir has mentioned, for the first 24 hours, we'll use like the higher fluid rate, and we'll probably want to do a clinical assessment somewhere continuously, and a lab investigation in the form of BON, creat, hemoconcentration, hematocrit at around 6 to 8 hours. If the child has presented to us in the first 24 to 48 hours. So first at 6 to 8 hours, you reassess whether your fluids are hitting it correctly or not. And after that, you can take a call, particularly on the next day, you can give normal maintenance, and you use, like, you keep on judging the clinical picture and then decide whether you want to go with a higher rate or lower rate. You don't want to load the child, you don't want to give the child hypovolemia, both. So initial maybe a little bit higher rates to perfuse the pancreas well, and after that maintaining it normal, looking at the clinical picture and maybe with the help of a lab.
I
So
think I
Dr. Madhuri, yeah, sir.
I
Dr.
think I
Bhushan.
think the main motto is to start enteral feeding as early as possible. So first, as Madam has said, so first 24 to 48 hours is a very crucial period. But if you see, if the child is stable, settled in a hemodynamic life, you start enteral feeding. So we instead of keeping starting enteral feeding, it will give very good response, and we can prevent the further complications.
So to both, I have one question. Number one is when we say 1.5 to 2 ml per kg, we are getting like, child with more than 40 kg and all. Now we have another problem. So
Sure.
do we take the actual body weight, or suppose I have a child of 60 kg. So if I give 2 ml per kg, it will be 120 ml per kg. So giving 120 ml per kg is 1.5 time approximate for a child, like, for 24 hours. So two questions. Do we give with this high dose based on what weight? And number two, what are the therapeutic endpoints with regard to clinical pointers of pancreatitis?
So Bhushan sir, will you be taking that?
Actually, I not understand second question.
So,
What are
I
the
will just
clinical?
take the.
Yeah.
See, what happens is, so this guideline that we showed is an adult guidelines, not the pediatric one.
Yes.
Yes.
So when we apply it to pediatric, what we do is basically for first like 10 to 20 kg, we give the fluid as 1.5 times the maintenance. Okay. And the second day, we make it as a normal maintenance. And third day, we further decrease it to around maybe 75% of the maintenance. So idea, end of the 3 days, your balance should be equal. It should not be fluid accumulation. Otherwise, they'll end up in ARDS. So initially more, then you cut down. Now, this is the time again when you are starting the enteral nutrition. This enteral nutrition is not 100% of the maintenance, it's the topical nutrition. So there is still probably the 50 to maybe 70% will be still IV fluid, 20 to 30% will be the enteral, and we, depending on the pain and the ileus, we build up enteral, decrease the IV. That's how we go, sir.
Yeah. And before the another question is, I've seen that we talk like, we recommend ringer lactate, okay, as a fluid of choice.
Yeah.
Right. So it is minus dextrose. So how do we take care of dextrose part, the calories part that we need?
Yeah, so in that situation, we give around 25% dextrose by the central line, and that maintains the dextrose concentration.
Okay, that we mean to say that we keep a dextrose like glucose delivery at the rate of 4 milligram per kg per minute, right?
Yeah, so depending on the weight, so that will vary. So if an earlier one may be lower, if the requirement is high, maybe 6 mg. So depending on, so we had a separate dextrose like infusion.
So even suppose Dr. Monica is asking, we want like, so Monica, you can give dextrose up to 12.5% from the peripheral line, no problem.
Yeah.
She says, yeah.
So another way is like peripheral line. You can give a combination of NS and RL. Like you can use 10% dextrose out of 1.5 times you want to as a dextrose containing and 1 time as a RL. So these things you can do and manage with the peripheral line.
Yeah. So alternate RL versus dextrose, right?
Right, sir.
Yeah,
Okay.
RL and DNS.
RL and DNS, right? RL and DNS.
You can use
RL and
combination.
DNS. Agree.
It may not be 100% RL if you want to maintain with peripheral line.
So thereby you are decreasing the chloride delivery.
Yes.
Yeah. And the last question is when we say
So
early,
even NS is good.
yeah. The last question is you said early enteral feeding. So early means how early? Because when we say यार feeding शुरू करना है तो ये करते करते average 3 to 5 days तो लग ही जाते हैं. Whatever, I mean, our experience is there with regard to pancreatitis. So early means how early? In a mild case, moderate to severe, we can wait.
Yeah, so moderately severe till resolution of ileus. In mild, generally we wait for the clinical response of the child saying that he is hungry. That is the best clinical indicator. So there's no role in monitoring amylase lipase. You have seen people who are doing daily amylase lipase and seeing the response.
That was
Dr.
my
Ronak
next
has shown you the slide, half-life. It's going to be elevated for days together. So you don't have, once you have documented, you don't have to do amylase lipase to monitor. The clinical response is the best guide. So why we have taken this acute pancreatitis case here is that to tell everyone that acute pancreatitis is a domain of a pediatrician and pediatric intensivist. Manage well, so complications you can avoid. So hardly surgeries is required. So I have not seen most of the only in the complications the surgery is required. It is not possible for any surgeon to go in and touch the abdomen in acute pancreatitis. So the decisions and our vital decisions are under our hand, our pediatrician's hand. Manage them well, manage the analgesic well. Once the child asks for a feed, give.
Okay. So to all three, one of my question is how frequent you get pancreatitis in a case of not as a case of acute abdomen. A child who comes to you like abdomen pain, and we do sonography, we don't sometimes get anything. Or sometimes we get mild, we don't get anything, and amylase lipase is elevated. So how early, how frequent you are getting acute pancreatitis in a case of pain abdomen?
Yes, Dr. Madhuri, Dr. Bhushan, they work on a very high volume centers.
Yeah.
So like majority pains are probably the ones which are probably coming chronically or recurrently most of them turn out to be functional. The ones coming as acute abdominal pains for the first time, probably severe enough, but like the case that we have, probably once in a month, I must be getting of all the pain and abdomen cases. So acute abdomen, maybe 1 in 15 or 20 cases that I'm getting, which is having a acute pancreatitis probably. Not that common, but it is like seen almost 1 month you'll get a case as far as I'm concerned over here.
I think I suggest there is a slightly increased numbers of acute pancreatitis cases. I think I got almost 3 to 5 or 5% to 10% cases they can have acute pancreatitis related with the junk foods. If the child has obesity,
Change in lifestyle.
right, our case. If you go with the case that our child's weight was 44 kg with the expected of 40 kg.
Yes.
So childhood obesity with a fatty food diet, that cases actually numbers are increasing. So I think that is the reason we should be alert and very aware about the acute pancreatitis. These are there and they are coming up. The numbers are increasing.
Yeah, because why I ask this question, I have my own little experience where I found the dull aching pain. We got first line of investigations, including sonography normal. And then the sample was, we have a policy of having a sample kept in the lab for 3 days. The plain blood sample and all. Nothing was coming. I said, just get the SGOT, amylase lipase done, and it was in thousands. Mild dull aching pain.
So I think any child who comes to
So,
with
you
a
know, that,
repeated abdominal pain, I think at least we document one amylase lipase at least once.
yes,
That's it,
I mean,
definitely.
now it's my second line of second stage investigations. If all my first stage investigations are negative, I just do amylase lipase, and then I have a couple of cases in last 5 to 6 months.
Yes,
Everything is normal. The dull aching pain, got amylase lipase done, elevated. Then we managed conservatively, and then managed. I mean, resolved.
Yeah, like maybe even I'll ask Vibhor sir a question. Like I saw one of these cases, a severe case, but the radiologically, the like of the three criteria, two were there. There was the pain was pretty classical, and amylase lipase was 3 times upper limit of normal. But repeated ultrasounds and CTs did not show any evidence of pancreatic inflammation. Can that happen? Like otherwise, the picture fit perfectly in moderate to severe pancreatitis. The child had severe, like initial abdominal pain, vomiting, amylase lipase very high, and classic abdominal pain, but imaging is normal.
Vibhor is there.
सर का कनेक्शन बीच बीच में ये हो जाता है.
So there is one question in the chat box. How often should a resolved case of acute pancreatitis be followed? I think here we want to say if it is a case of acute interstitial edematous pancreas. So there is spontaneous recovery is very high. So even if it is cirrhosis, they get 30 to 40% resolved. But if it is a wall of necrotic pancreas, that cases there is a chances of developing complications are there. So resolving or complete resolving we can get in almost 40 to 30 to 40% cases if it is a mild pancreatitis case. 100% recovery if it is without any complication. One more question related to fat, I think.
Which autoimmune diseases are more
Yeah.
prone?
How much fat can be allowed in the enteral feeding? So I think there is a no efficacy differentiate between polymeric feeding and semi-elemental feed. So probably go with the low fat 30% and then slowly increase to the 30 to 50% fat we can allow if you are starting with the feeding.
So, like there's a very nice phrase used in the article that Dr. Ronak has referred to, gut rousing rather than gut rest. So like we want to give some activity trophic feeds to the gut in the form of a low fat diet.
Hello.
Yeah.
In a very low index of suspicion of pancreatitis, are we justified in doing both amylase and lipase or only lipase?
Ronak, can you answer the question?
So the definition of acute pancreatitis is the elevation of serum amylase and or lipase to more than 3 times upper normal limit. So
So the early to rise is amylase.
Yeah.
Early to rise is amylase. So if you want to choose one, you choose amylase. But amylase at the same time is very. So you can do both amylase
as well as lipase, so that investigated late, then lipase may be positive.
So sometimes we do get that kind of presentation. Very difficult because if you see lab to lab, upper limit is different. So the reagents, the machine, they are very different. So it is difficult to correlate. As Dr. Madhuri, sometimes the ultrasound is unreliable because of it is subjective. Sometimes entire pancreas may not be involved. It may be a portion of the pancreas may be involved. And sometimes because it's a retroperitoneal organ, ultrasound is not very good modality to evaluate the pancreas. So for our when you are dealing with the younger kids, again the clinical signs are not reliable. Examination, but the history, the typical pain is again not reliable. So the diagnosis in pediatric can be very dicey.
Yeah.
It is difficult to diagnose.
Yeah, totally agree. The clinical as well as radiological needs lot of high index of suspicion. I mean to say.
Yes.
Exactly.
Yeah. So yeah. So I think it's the 30 past 10 now. Sanjay sir, with your kind permission, can we wind
Okay,
up now?
last question. Which autoimmune diseases are more prone to get pancreatic inflammation and be on high on suspicion? Last question in chat box, guys.
Okay. Autoimmune condition associated with pancreatitis.
So autoimmune pancreatitis is a well-known entity actually. If you have most of the idiopathic pancreatitis, if we have to document for it is autoimmune or not, we have to send IgG4 level. So if the serum IgG4 is increased, if the child has fever, persistent fever with a pancreatic picture, and in that case you can suspect about autoimmune pancreatitis and document for do the serum IgG4 level. If it is raised, that is definitely then it is a case of autoimmune pancreatitis. Autoimmune is a multi-system involvement. So if you are having child with hepatitis, then pancreatitis can be possible. So that's why autoimmune suspect with the specifically multi-system involvement and more severely arrangement of the female child. So that's are the few things we can consider autoimmune pancreatitis. It is there.
Okay, the
Yes.
last question about parasitic pancreatitis. Parasitic cause of pancreatitis.
Yes.
Yeah, anyone, then we'll stop.
Yeah,
Madhuri,
particularly if you like maybe like you ascaris can cause, like particularly if you have got some sphincterotomy done. In that case, also probably it may result in the worms migrating and causing pancreatitis. That would be one possibility that is there.
It is very
Yeah.
uncommon in
Yeah.
pediatric age group. We commonly seen that parasitic pancreatitis in adult. In the while doing ARCP, we can get that all this. Pediatric is very
Yeah.
uncommon, but it's still it is there. If a child is in remote area,
Yes,
history of worm,
epidemiological means we
yeah,
should
yeah,
say
that
which
we
age.
can think about. Yes, definitely.
Yeah.
So we have seen this very commonly in northern states of India. Somehow in western state it's not seen that common. But while working in the Chandigarh and Lucknow, we have seen lot of. It is very well picked up on ultrasound and MRI. Sometimes this worm can die there, and then the therapeutic like ERCP is required. It has a very classical finding on MRI and an ultrasound. So fortunately, we don't see that common in Maharashtra.
We do very regular deworming. Here the parents are also doing deworming by every weekly and every monthly.
Okay. So Dr. Manish is there. Manish Tiwari,
Yeah, sir, I'm there.
please, vote of thanks.
Yes. Sir. What a wonderful presentation and discussion. For this, I would like to thank our President, Dr. Pakmode sir and Dr. Sanjay Deshmukh sir for taking the initiative to start this webinar. Thank you, Dr. Amol Pawar sir and Dr. Minaj Sheikh sir for helping out with the logistics. And really, it was a great discussion. We see both pancreatitis as well as patients of neonatal cholestasis very frequently in our setups. Thank you, Dr. Vibhor, for moderating the sessions. Dr. Ronak for excellent presentation, and our eminent guides, Dr. Madhuri Madam and Dr. Bhushan Mirje. Thank you so much for your guidance. And especially thank you, Dr. Pranoti, for moderating the session initially in my absence. Thank you so much. And finally, all the participants who have joined and have taken active participation in the discussion. And as per our discussion, I would like to appeal all the delegates to kindly register for the Mahapedicon 25 at Kolhapur.
Thank you. Thank you.
Uh,
Thank you.
with the
It was really
Just
wonderful, Vibhor, Madhuri Madam, Dr.
yeah,
Bhushan, and
just
Ronak.
Yes,
Excellent presentation.
yes, and even the
Excellent.
Raunak
just one
also.
acknowledgement. Just one acknowledgement. Both these cases were from Sion Medical, Lokmanya Tilak Medical College, and Raunak has taken permission from the department, and he has managed this recently. Okay.
Yeah, great.
Very
I
commonly,
mean,
wonderful presentation, and that too on the very common cases we usually come across where we
yeah.
need really insight into that,
I mean,
and that you have shown. So great enlightenment from Vibhor sir, and again Madhuri Madam and Bhushan sir. Thank you very much.
Yeah.
Heartiest congratulations to
Thank-
Ronak, Dr. Ronak. Very
you.
nice presentation, and thanks to Vibhor sir for the entire panel. It was very well arranged. It was a learning opportunity for me as well. Thank you so much.
Yes,
Thank you.
thank you, my PN sir.
Yeah, thank you everyone.
Thank you,
Thank you,
everyone.
sir. Thank
Good
you.
presentation, Ronak.
Thank you.
Thank
We
you.
will
Thank
leave.
you,
Thank you.
Vibhor sir, Madhuri madam, Bhushan sir, and
Yeah. Good